Hi, pathology buddies. Good morning, good afternoon, or good evening. In this part 4 video of how to approach a GIT lesion, I want to mainly concentrate two very essential things. We will see in a minute. Again, the tagline for this whole presentation is, at the end of seeing all these videos, you should have a very good gut feeling when you are seeing GIT biopsies. GIT is a major organ in our body, and we never think of the effects of medications. Whenever we talk about medications, we think of liver and kidney, as most of them are metabolized in the liver, excreted in the kidney. But medications has a major effect on GI tract. Let us see the changes that medication can do to the gastrointestinal tract. Along with that, that's an interesting topic of increased apoptosis, which is called apoptopathy, that affects GIT. Again, these are main 4 references. Dr. Elizabeth Montgomery has a very great video in Pathcast on the effect of medications. The topic of that video is iatrogenic changes affecting the GI tract. I strongly recommend you to watch that video. So we can divide the medication effect in the GI tract by the system of the GI tract that is affected, for example, esophagus, and this gives a big list of medicines that affect the esophageal mucosa. This one is the main medications that can cause changes in the stomach. Small intestinal mucosa can be damaged by these medications, and large intestinal mucosa has a big list of medications that can affect and cause pathological changes. I thought rather than doing a region wise, let us put together everything and what are all the main events that can be caused by medications. And I want to do it in 10 major headings. It can be ulcer and stricture. All these are caused by medications. Ulcer and stricture, ischemic changes, perforation, microscopic inflammation or infectious disease like changes, focal acute inflammation, medication that can cause chronic inflammation, medications that causes increased apoptosis, that causes mitotic arrest, and miscellaneous medications causing other effects. So these are all the 10 major headings, and under each heading we have a list of medications. I'm not going to read all of them, but I will read one or two. Please remember NSAID, they will come in most of these changes. They can cause anything starting from ulcer stricture to chronic inflammation. Here raisins like axalate, we have to concentrate, and I will be showing you nice pictures about them in the ulcers and strictures. Ischemic changes can be caused by these drugs. Again, as I told you, you can see NSAIDs. Non-absorbable drugs like raisins, like axalate and sevelamer. Cocaine can cause ischemic changes. Medication that cause perforation or corticosteroids and non-absorbable drugs. Again, axalate you can see there. Microscopic inflammation can be caused to many of the medications. Please keep this list with you. Focal acute inflammation can be caused by mycophenolate, NSAIDs. Infection-like changes can be caused by corticosteroids, clindamycin, penicillin, sulfonamides. Chronic inflammation can be caused again by rituximab, tumor necrosis factor, NSAIDs, mycophenolate. Apoptosis can be caused by a number of medicines. We have to remember NSAIDs, mycophenolate. Mitotic arrest will be caused by colchicine and Taxol along with cyclosporine that are given intravenously. And the miscellaneous medication that can cause various changes are yttrium, the lifting agents, we will see nice pictures of that, tattooing India ink, laxative abuse, and medication fillers. So these are all the major list of medication that causes 10 changes in the GI tract. And let us see one by one by nice pictures. Before going into individual case, history, and history. Whenever you see some changes in the biopsies, either from the esophagus or stomach or small intestine or colon, always see what are all the medications the patient is taking. Why I am stressing? We mainly think of liver and kidney, as I told you before, for medication history, and please include GI tract also, because medications can cause anything that you can see under the microscope. History solves the mystery, and this table gives the details. These bile acids are given for sequestrants are given in case of diarrhea, so the patient should be having a history of diarrhea, and biopsy may show this. It doesn't cause any mucosal injury, but the crystals can be seen as bright orange or pink color or red color with no fish scale in the HNE, and in AFB it will be dull yellow in color. Coaxalate is usually given in chronic renal failure. It is a potassium binder. It causes mucosal injury. It can produce ulceration, it can produce ischemia, it can produce perforation. So whenever you see this, look for mucosal damage, or whenever you see mucosal damage in a chronic renal failure patient, look for this crystal that is purple with fish scale-like appearance on HNE and black in AFB stain. People are thinking it is not predominantly due to coaxalate, but most of them are given along with sorbitol, and that sorbitol is causing that damage. Silver, this is also given in chronic renal failure patients, and it is a phosphate absorbent material, and it can also cause mucosal injury. It shows two-tone appearance. It will be having pink and yellow appearance. Again, fish scale will be there, and it will be magenta in color in AFB. These are all the three crystalline structures by which resins can appear in the mucosal biopsy. Now we are coming to the esophagus, where there is a condition called esophagitis dissecans. It may be usually seen in elderly people with polypharmacy, where the mucosa of the squamous epithelium of the esophagus is lost in a linear fashion. These are all the intact, where it is more pearly white in color, whereas the salmon color is the submucosa. And these mucosa may be seen endoscopically as clinging paper. This is also known as sloughing esophagitis, usually seen in NSAID and bisphosphonates. Microscopically, it shows a two-tone appearance. Top will be pink in color and the bottom will be blue in color. You can see better here. So it shows more hyper and parakeratosis in the top layer, and the bottom layer will show more basal cell hyperplasia. So it will be pink and blue color seen in esophagitis dissecans, and it's a endoscopic and pathological diagnosis. Here, this is a gastric biopsy where you can see crystalloid structures, pigmented crystalloid structures. Here, these crystalline structures are positive for Pearl's Prussian blue. So this is a iron precipitate. Usually it is seen in people taking iron sulfate, and the differential diagnosis is siderosis. In siderosis, you see the pigment in the parietal cells and in macrophages. You don't see them in the top of the mucosa. So when you see iron pigment in the parietal cells or within the macrophages, think of siderosis, and you know the causes of siderosis: recurrent blood transfusion, thalassemia patients. So those are all the patients you have to ask for clinical history. This is a gastric biopsy that characteristically shows a dilated glands, and here the parietal cells are hyperplastic and they are having apical snouts and some hobnailing. This is a classic example of proton pump inhibitor changes seen in the gastric epithelium. In this gastric biopsy, you can see the widened lamina propria with some macrophages. When you go it in high power, these macrophages are having some crystalline structures. In that material, they are brownish purple amorphous material in the macrophages in the lamina propria. High power you can see better within the macrophages, and when you do oncosa stain, it will be positive. So this is mainly due to lanthanum carbonate. Lanthanum carbonate is used in chronic renal failure patient. It's a oral phosphate binder and it causes lamina propria expansion by histiocytes with the characteristic inclusions. Here this is another gastric biopsy. Here you can see fibrinoid material deposited in the capillaries, ring-like fibrinoid material in the capillaries. High power view, you can see them better. And this is a classic side effect of tetracycline or doxycycline. We may be seeing most of them and we may be ignoring them. My kind request is, again, whatever you see, you note it down and try to identify the cause. Now it is very easy in Google. Just go to Google and put fibrinoid ring-like structures in the lamina propria in the blood vessels of gastric mucosa. You will get the diagnosis immediately in the Google. So Google is your friend in difficult cases or when you see structures which you are not familiar with. Please use it. This is a colonic biopsy. Here you can see coral, sea coral-like material, and if you see carefully, some dirty brownish material is also seen in the mucosa here. And I'm just cheating you. These are not from the GI tract. These are from the lung. And this is the coral-like material in high power. And this is the amorphous material, which is without any color in this biopsy, colonic biopsy. But when you put under polarization, you can see a beautiful picture. See here, the coral-like structure is not refracted, whereas the colorless structure is highly refracted. And I have to thank Dr. Sanjay Mahobutiaya for this beautiful picture. These are nothing but medication fillers. See, the medications in any tablet or any pill, the medical component is little bit supported by the non-medical fillers to give the bulk for the pill. These are known as medication fillers, and the coral-like structure is known as cross-povidone, that is not refractile under the polarizing microscope, whereas the refractile structure under the polarizing microscope and the colorless or bluish or brownish tinge-like material is microcrystalline cellulose. Cross-povidone or microcrystalline cellulose are the two medication fillers. You have to keep it in mind. Here you can see nice round microcrystalline structures. See, they are all uniformly sized and they are predominantly seen within the blood vessels in this gastric biopsy. This I got it from Twitter from Dr. Miriam Puizo's page, and these are nothing but atrium particles. These atrium particles are used in thromboembolization or chemoembolization of the tumors, predominantly hepatocellular carcinoma. This is a section from the liver. You can see that particle and you can see the viable tumor cells, whereas here all the tumor cells are dead. These are chemoembolization radiation particles, atrium particles. Please keep them in mind. They are seen predominantly within the blood vessels. From the liver or from the organ wherever it is injected, they can get into the vascular system and can present in any part of the GI tract. This is the picture of Mary Mpezu. She, along with some of her colleagues, started seeing this amyloid-like material in the lamina propria of the colon. This is the high power view. You can see the acellular fibrillary eosinophilic material, and that has a lot of giant cells around them. And plasma cells are not seen that much. You can see it in high power, the giant cell reaction for this acellular eosinophilic fibrillary material that are Congo red negative. Since Congo red is negative, and because of extensive giant cell reaction without abundant plasma cells, they are thinking of something that looks like amyloid. So they went back to the clinicians and asked them, all the material where they have seen this, all these specimens had a previous history of polypectomy. And from the clinicians, they came to know that they are using the lifting agents during the colonoscopy. Usually they use saline or glycerol. Now they started using ORICE or Eleview because this is better than the saline and glycerol structures. After getting that history, and they got the picture from the clinician. So this is a polyp where it is not seen very defined way. But after the lifting agent injection, you can see the nice outline of polyp, and this will help the clinicians to snare it completely. And this is after removal of the polyp. You can see the lifting agent as some bluish gel-like material here. What Dr. Merriam did, she took the ORICE gel and Eleview gel, and she prepared it in like a cell block. The ORICE gel, it underwent the process and it was seen in the slide from the paraffin sections, whereas Eleview, the material was not present in the paraffin sections after processing. So what they did is they got specimens from the clinicians immediately after ORICE injection, 1 day after ORICE injection, and after 3 months. These are all from the clinical history, they got it. And after 1 day or immediately after the injection, it morphologically very similar to the ORICE that is seen in the paraffin block. Whereas when it is for a longer duration, they started looking more like amyloid. Those amyloid-like material are trichrome positive, PAS positive, HNE again looks like amyloid, Zeal-Nielsen negative. And Congo red, here it is the HNE and here it is the Congo red. The Congo red is negative, whereas a control amyloid is positive. Pulse granuloma is another thing that can be the differential, and here you can see, can you see the coral-like material? This is cross-povidone. They are also Congo red negative. Congo red is positive only in amyloid. So they thought this is amyloid-like material because of the mucosal lifting agent. And they nicely presented it in American Journal of Surgical Pathology, June 2020. You can see this under characterization of novel injectable lifting agents used in colonic polyp removal. See how they're paying attention to all these structures is helping us. We have to thank Dr. Merriam and their colleagues for bringing this into our awareness. Another small point about amyloid. Amyloid is usually seen in the submucosa also, and they will be seen around blood vessels. Whereas these ORICE and Eleview, they are seen predominantly in the lamina propria with extensive giant cell reaction and without perivascular distribution. That's another point of differentiation. This is another biopsy, colonic biopsy, where you can see the mucosa, muscularis mucosa and the submucosa. In the submucosa, you see black pigments. When you go to the high power, a lot of macrophages are there filled with black pigments. Okay. Again, after seeing this, they went back to the clinicians and asked them what they did here. They removed a polyp, and since it was looking very suspicious, they injected India ink at the site of the polyp. That polyp biopsy was diagnosed as a high-grade polyp with focal invasion. So they went and did the segmental resection of the colon by identifying the submucosal India ink. And that's why India ink is present like this. So this is conditions where they inject India ink in case if they want to go back, and the India ink can be seen like this on the serosal side and like greenish black on the mucosal side. One of the differential diagnosis here on the serosal side, when you see them without the history, it may look like endometriosis in case of females. So please remember the India ink tattooing in suspicious cases. Whenever you see black pigment in the resection specimens, ask for India ink tattooing. Here these you might have seen frequently. We see it a lot in India. You see a lot of brownish pigment laden macrophages that are negative for Prussian blue, because they look like hemosiderin, but they are negative for Prussian blue, and they are predominantly seen in the lamina propria, and these are nothing but lipofuscin. And when you ask for the history, the clinicians will give you the diagnosis. It is jet black colored mucosa predominantly involving the colon. Here you see the ileocecal valve, which is not involved. Only colonic mucosa is involved, and this is nothing but melanosis coli. And this is a misnomer because these are not melanin pigments. So this should be called as pseudomelanosis coli, and these are the lipofuscin, and they are predominantly seen in laxative abuse. Now we are coming to non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs can produce anything. It produces chemical gastritis, ulcers because of ischemia that can induce, which is more common in the right colon. It can produce diaphragm. This is one of the best examples of diaphragms, which are nothing but circumferential narrowing of the small intestine because of the submucosal fibrosis. You can see a very nice section of diaphragm disease due to NSAID use, and it can also produce reactivation of IBD, or it can produce colitis. It can produce pseudomembranous colitis, and it will also cause perforation of the diverticulum. This picture shows you gastric mucosa, edema in the lamina propria, and you see the muscles coming up there. Muscularization of the lamina propria. I think in part 1 we talked about it. This is characteristically seen in chemical gastritis. And these two are diaphragmatic disease, circumferential folds in the small intestine because of submucosal fibrosis. And these two are from acute colitis. You can see the ulcer here, and crypt abscess here, and cryptitis here. This is focal acute inflammation. All of these patients has a history of non-steroidal anti-inflammatory drugs. This is the continuation of the non-steroidal anti-inflammatory drugs. These are characteristic welcome appearance, which is pseudomembranous colitis, and these are lymphocytic colitis where the lymphocyte number is increased, more than 25 lymphocytes per 100 epithelial cells. Here you can see a lot of eosinophil. So this is a characteristic eosinophilic colitis. Here you can see the thickened collagen plate beneath the lining epithelium. So collagenous colitis. And here you can see the preserved crypt in the base, whereas the top is gone, and there is some ulceration. So these are ischemic changes. So these are all the spectrum of changes that can be produced by non-steroidal anti-inflammatory drugs. And whenever you see pseudomembranous colitis, also ask for the history of clindamycin. You all know clindamycin can cause Clostridium difficile proliferation and pseudomembranous colitis. Now we are coming to medications given for malignancy. and these changes are seeing more often nowadays. And broadly speaking, the medications for malignancy can be classified into proliferation inhibitors or immune modulators. How the proliferation inhibitors act? They cause mitotic arrest, and in the GI tract, you all know it is highly proliferating area. So these mitotic arrest can be seen in the epithelium, and they will be seen as ring forms. We will see nice pictures in a minute. The best example are Taxol, cyclosporin, and colchicine. Colchicine arrests the mitosis in the ring forms. That's why they use it in chromosome cultures in karyotyping. You have to remember that, and whenever you see arrested mitosis, increase ring forms in GI tract, you have to ask specifically for these three medications. And other chemotherapy agents can also cause this. The immune modulators, basically they stimulate the immune system and predominantly the T cells. So what happens? These stimulated T cells cause the death of the tumor cells, and in the background normal structure get autoimmune diseases because it's a stimulation of T cells. So it produces autoimmune diseases in the non-tumor areas. That's what happens in the GI tract. There is lymphocytic attack on the epithelium, increased number of apoptosis are seen, and loss of specific types of cells. For example, parietal cells in stomach, Paneth cells in the small intestine, goblet cells in the small and large intestine. Loss of them happens, and this is also known as autoimmune gastroenteropathy. And the most commonly used immune modulators nowadays are anti-PD1 and anti-PDL1 and anti-CLA4 for melanoma, whereas PD1 and PDL1 they are started using in all type of tumors wherever they express the PD1 or PDL1 by immunohistochemistry. We will be getting more and more of these, so you have to aware whenever you see autoimmune like changes, we have to think of immune modulator therapy. This is an example of esophageal biopsy where you see the increased number of mitosis. See the mitosis. They are all chromosomes. They are all getting some music and they are all dancing chromosomes. Okay, chromosomal arrest. Think of these medications. And this is a gastric biopsy where you can see increased number of ring mitosis because of the mitotic arrest. Okay, please, whenever you see this many mitosis without any cytological atypia, please think of medications. As I always tell, mitosis and atypia should go hand in hand. When you see only mitosis or only atypia, be careful before diagnosing malignancy. The immune modulators, as I told you, they cause apoptosis, and a lot of other things can also cause apoptosis in the GI tract. So I want to discuss them as the last part of this video as apoptopathy involved in the GI tract. The normal number of apoptosis you can see in the small intestine is 3 per 100 crypts, whereas in the colon it is 1 per 10 crypts. You should not see any apoptosis in the esophagus or in the stomach. Increased number of apoptosis can be seen in these 6 conditions. With the bowel prep, you can see increased apoptosis, graft versus host disease, medications as we talked about before, checkpoint inhibitors, infections like cytomegalovirus, and another very important disease you should be aware is common variable immunodeficiency and in autoimmune gastropathy. From the history, we can differentiate them. So for example, graft versus host disease, the patient should have a bone marrow transplant and skin involvement should be there. This is very, very important. And in the gastric biopsy, the apoptopathy with the graft versus host disease won't show increased number of eosinophils, and they will also show neuroendocrine hyperplasia, neuroendocrine cell hyperplasia in cases of graft versus host disease. So skin involvement and eosinophilia with the history of bone marrow transplant favor a diagnosis of graft versus host disease. Medications, mycophenolate and checkpoint inhibitors, and more importantly, some antihypertensives, angiotensin 2 receptor blockade medications can also cause autoimmune enteritis like changes. So, increased apoptosis can be seen. So, whenever you see apoptosis, always ask for history of antihypertensive medications also, in case if they are not taking any immune modulators. CMV can cause increased apoptosis. In combined variable immunodeficiency, another important feature is plasma cells. They will be less or absent in the mucosa, and there will be a clinical history of hypoglobulinemia, which is very important because here the mature B cells and plasma cells will be absent, and gamma globulin, especially IgG, IgA and IgM, will be very less in amount. Autoimmune gastropathy, again you can see no or less specialized cells like parietal cells, goblet cells and Paneth cells, and serologically you should have anti-enterocyte antibodies. So clinical history is very essential. Let us see some pictures now. In this composite picture, this is the colonoscopic view where you see a lot of apoptoid ulcers, but the remaining mucosa is normal. And microscopically, you see very focal cryptitis, increased number of apoptosis and neutrophils. When you ask for history, there is no history of bone marrow transplant or any other thing. And when you don't have any other history, you have to think of bowel preparation when it is seen very focally. And you see how nicely all the glands are uniformly sized, shaped and distributed. These are all the factors that favor bowel preparation changes. Here it's a 45-year-old male with hypertension, complaints of diarrhea. So they took the duodenal biopsy because they don't have any explainable reason for the diarrhea. Mild villous blending is there, and in the high power you can see increased number of lymphocytes, and see the goblet cells are very less in number, and there are no Paneth cells at all, and you start seeing increased number of apoptosis. So this is more like autoimmune enteropathy, but the patient is having a history of hypertensive. So when you talk to the clinician, you will get the history of olmesartan treatment. This is a angiotensin 2 receptor blockade medication used very commonly in hypertensive patients. But please remember, anti-PD1, PD-L1, anti-CTLA4 can also produce same picture in addition to autoimmune enterocolitis. This is a picture where you can see composite image of 4. You can see in this portion of the picture, the crypts are normal, but there is slight increase in the number of apoptosis. Remember, you can see one apoptosis per 10 crypts in a colon, whereas here it is more than that. In this, you see some dropout. Some of the glands are dropped out or damaged. Here you can see more damage, and the lamina propria is becoming more prominent, and increased number of apoptosis are present. Here there is total loss of epithelium with ulceration and ischemia like changes. So whenever you see these type of changes, increased number of apoptosis without lamina propria inflammation. That's why this is also known as quasi-inflammatory or deserted pattern. You have to think of graft versus host disease and act on the history. History of bone marrow transplant is very essential. And these are all various grades. The common system we use is a Lerner's system. Grade 1, apoptosis with no dropout. Grade 2, single crypt dropout. Grade 3, contiguous crypt dropout. And grade 4 is diffuse crypt dropout with ulceration. So these are 4 grades of graft versus host disease. And please note the paucicellular lamina propria and eosinophils are not increased in number, because whenever you see apoptosis due to medication, the eosinophils will be increased. That you have to keep it in mind. This is a more high power view to show extensive ulceration and gland dropout and increased apoptosis. And here you can see the dropouts, okay, and focal cryptitis and increased apoptosis, but no eosinophils in the background. Increased apoptosis again. So this will be grade 2 and this will be grade 4 graft versus host disease. Please remember history of bone marrow transplant, skin involvement and lack of eosinophils in the lamina propria is very essential to diagnose graft versus host disease. This is another GIT biopsy where you can see increased number of apoptosis. Okay, I think you can all appreciate the increased number of apoptosis here. And in addition to that, you can see abundant eosinophils in the background. Whenever you see apoptosis with abundant eosinophils, ask for medication history. And here the patient is on mycophenolate. Okay, that's why it is causing apoptosis in the GI tract. This is a 32-year-old female with chronic diarrhea, duodenal biopsy. Again, severe villus atrophy. It looks like celiac screw in the low power. But when you go to high power, the intraepithelial lymphocytes are not increased and it shows lot of apoptosis. And when you look into the lamina propria, you see less number of cells and plasma cells are very much reduced in number. This is a case of combined variable immunodeficiency. And when you do CD138, which is a marker for plasma cells, in severe cases, you may see absence of plasma cells or 1 or 2 plasma cells. And this is the built-in control. And please remember, CD138 is positive in the colonic or small intestinal mucosa. So this is CD138. And so this is a classic for combined variable immunodeficiency. Ask for the clinical history of hypogammaglobulinemia. Here you can see the intranuclear inclusion. These are more like Cowdery type B because they are not very prominently seen with the perinuclear halo. And you can see increased number of apoptosis also there. Okay, and most of the inclusions are seen within the endothelial cells. That's why it produces ischemic changes. And another interesting thing, CMV affects mesenchymally derived cells first. That's why endothelial cells and fibroblasts are affected first and produces ischemic changes. So I think the pathologists, sometimes they should act like Sherlock Holmes. Be very careful. And sometimes they should act like James Bond. Whatever is available, we have to do it very quickly. The difference is James Bond, when you act like a James Bond, you prevent the disease because these are more like preventive action, whereas Sherlock Holmes more like a corrective action. So we should be a good combination of Sherlock Holmes and James Bond. To conclude, GI tract can be affected by medication. Please remember, along with the liver and kidney, whenever you see GI biopsies, ask for medication history, look for medication induced changes. And certain diseases can cause increased number of apoptosis, which is normally not seen in GI tract. The medications can cause changes because of their physical presence or because of the chemical nature and because of the action on the cells. So they can produce ulcers, strictures, ischemic changes and perforation. They may produce microscopic inflammation, focal acute inflammation or chronic inflammation, and they can produce apoptosis, mitotic arrest and miscellaneous changes. And whenever you see increased apoptosis, think of immune modulators, autoimmune disease, graft versus host disease, infection especially with the CMV, and combined variable immunodeficiency, where the plasma cells will be very less or absent. So I think you enjoyed this video. Thank you very much and have a great day, and see you in the next video. Bye bye.